States Army, Wisconsin National Guard. She's been in the behavioral health field with the Army for over 14 years. In 2016, she was then COIC of providing combat operational stress control for 2,500 soldiers in Iraq and Kuwait. In 2015, she provided behavioral health care during martial law in Baltimore, Maryland. She has participated in training events providing behavioral health care in California for community mass casualties. In 2017, she was activated to provide behavioral health services in the midst of Hurricane Harvey. She's been a disaster mental health responder with the Red Cross since 2009 and has provided care during tsunamis and landslides in Hawaii. She was deployed to Louisiana to assist with providing disaster mental health during Hurricane Isaac. I'm so honored to introduce Dr. Skelton to you all this evening, and so happy that she was willing to help us in this time. If people have questions throughout Dr. Skelton's presentation, please enter them in the chat box, and she will save some time towards the end for a bit of Q&A. With that, I turn it over to Dr. Skelton, and thank you all for joining us.
So thank you so much for having me and as well as joining me this evening. I appreciate everybody's time and coming together to discuss a really important topic. Before we get started, I just have a few disclosures. I am currently employed by Texas A&M as well as the United States Army. However, when I am training, I am not representing the official views of either of those capacities. I am not making any financial gains, as far as I know, from any kind of advertisement or endorsement of anything in this training. And then finally, because I am still a member of the armed forces, there may be some things that I will not discuss or provide a personal opinion on. This isn't necessarily because I have access to top secret information, really just in a public forum. As a service member, I will remain apolitical. Okay, so let's talk a little bit about what my intention is today, and it's really to share some experiences. You've heard about some of the opportunities that I've had to provide behavioral health care in disaster emergency management situations, and so I hope to share some of that experience with you, and hopefully it will create some dialogue, also normalize operating in not normal situations, and just give us some reflection for thought. I have a picture in here, a slide of pictures, because I believe in the power of storytelling and oral history. And so what you are seeing here on the left and the right in the top corners are pictures of that mass casualty training in San Jose, California, where we were able to come together with military, government, and community agencies and respond to a notional mass casualty. On the left-hand bottom side, that is a picture of the place where the Red Cross volunteers were sleeping in the midst of Hurricane Isaac. And in the middle, what that is kind of a way of being creative in the middle of Tajia, Iraq, when we were providing behavioral health care. And then on the bottom right is a picture of our office in Kuwait, and kind of using a lawn chair and whatever we had access to, and again, being creative in the middle of a war zone. So let me just say a little bit about why I created this training. I have found that as COVID-19 was starting to kind of kick off and changes were starting to be made in terms of how we were going to deliver services, I found myself kind of experiencing a lot of anxiety and stress. And so when I took a minute to reflect on that and was thinking, I don't understand why I'm feeling this. I am confident in my ability to provide services, to take care of people in a crisis. I'm pretty adaptable. I'm used to working in this type of an environment. What I realized is that it is very different than what the precedent has been for providing behavioral health care in a disaster, in a war zone, in a emergency situation. And that is because for one of the first times ever, we have the capacity to be able to provide services via telehealth. And so very early on, there was this significant push to get us trained in telework and what the challenges were and ethics and the technological things that we had not previously had to deal with when working in an emergency situation. Because of that capacity, it was also sending some explicit messages and implicit messages that the only thing that was changing was that it was the modality. We're just going to telework. And, as I started having more and more conversations with my clients, I realized, that's not necessarily true. It's more than just the modality, although that is the way that we are offering services, but also it's in the middle of a global pandemic. Another challenge that I realized was different was that with COVID-19, we are really kind of addressing and fighting what is invisible. It's a virus, it's not something that we can necessarily see. Unlike a hurricane, where we are consistently being bombarded with pictures of the structural damage, the flooding, the people sitting on top of cars. When I'm providing behavioral health services in the middle of a war zone, we have on bulletproof vests, we have on helmets. There is this very visual, real sense that this is not business as usual. Also, for many of the natural disasters in the United States, there is some sort of understanding or precedence of what the expected timeline for recovery is. And with COVID-19, not only are we unsure, but the guidance that we're getting about how long to prep for or how long this will last is a ever-moving line. And so because it's unprecedented for us, it is just a different feeling or situation. Also, what I found, because we have the capacity to offer telehealth, is that the way we were defining things was different. So in all of the other situations where I was providing behavioral health care, we were defining it as crisis care or emergency care. And with my documentation or conversations, it was almost as if it was a regular session. And I think it's really important for us to think about this and think about the implications of this, because all of our licensing boards, our ethics, our peer consultation, there tends to be certain different stipulations for if we are handling or dealing with an emergency situation. And so I think it's really important to be documenting and thinking about and conceptualizing that this is not normal operations, and there's going to be some impact for that. And we'll talk a little bit more about what that looks like in a little bit here. So you will notice that I very intentionally use the word considerations, and that is because these are just me sharing my experiences, my thoughts as I am able to compare and contrast to some of these other different situations. Some of these are shorter term and some are more longer term, and so just an opportunity for us to reflect and grow and potentially kind of talk about some experiences that we're all having as a way of support. So one of the first things that was something that I struggled with was this idea of boundaries. And so I am pretty adept at embedded behavioral health care. Being in the military has provided me with some unique opportunities to, have my clients be urinalysis observers, to sleep in the same rooms, to shower and use the latrines in the same area, oftentimes without even a door. And so I have some experience with navigating what that looks like when you're sharing a very intimate space with your clients. However, what I recognized is that one of my very first telehealth sessions with my regular clients from Texas A&M, a student, is they very normally, out of just kind of regular curiosity, asked, "Is that your home?" And I found myself being really uncomfortable in the moment and trying to very quickly move on past that. And after our session, I had some time to reflect on that, and I recognized that it was because I was not ready for that. I didn't process that. I actually did not invite somebody into my home. It was out of a necessity to continue to provide services to people, and this was the only way to do it. So if we look at some of the literature prior to COVID-19 about telework, remote work, virtual work, what we know is that up to 84%, depending on the literature you're looking at, of the US workforce preferred the option to be able to telework, with the advantages being things like um, uh, more autonomy and more flexibility for your schedule. And so um, prior to COVID, those were things that could be worked out, that the schedule could be accommodating. And what we are seeing now after COVID-19 as a response to the global pandemic is that there were organizations and people that were unprepared to do telework. And so there hasn't been much time to really process, think, or strategically plan what that is going to look like. So what I have found in my experience is that there are some organizations that are sending the message that your time is going to be the same exact time as what it would be normally. Prior to COVID, that was considered to not necessarily be the way that telework worked. And so the idea that when you are teleworking, you actually can be more effective and more efficient, again, depending on the literature that you're looking at, reducing up to 11 hours off of a 40-hour work week. But with this new way of providing services, people that maybe didn't have as much experience with telework are expecting the time that you're spending in front of the computer to be the exact same time that you would spend in an office without some of those natural breaks that you would be doing in the organization. This idea of availability. So I have seen emails from people at 4:30 in the morning, at 12 o'clock at night, at 1 in the morning. And while this may be an adaptation to people that are working when they have availability, meaning the kids aren't up, or I can't sleep, I'm just going to send these emails. If it is not transparently discussed in your organization what the expectations of availability are, that can really send a message of expectation of being available all the time. And we would not, in normal situations, recognize that as being healthy. And so just some things for us to be considering when we're thinking about boundaries and how that has changed with COVID-19. For self-disclosure, what I have found, some of you may find this a little bit easier depending on your orientation. You may use it regularly in therapy. I know there is kind of split decisions on how to use self-disclosure in therapy, but I have found that for COVID-19, self-disclosure has allowed me to open up some conversations and normalize some of what people are experiencing. And so, for example, I had a client who was struggling with writing her thesis, and was talking about how she couldn't focus and she couldn't concentrate. And I was able to share with her that it has taken me 3 times as long to do my dishes because I keep getting up and then coming back in front of the computer and getting up to do something else and sending an email. And you could really just see the relief on her face that it wasn't her, it wasn't an increase in her anxiety, she wasn't failing, but that it was, an adaptation to she's now working from home on her couch trying to finish her thesis. And so I encourage you to think about, using self-disclosure in a thoughtful, intentional, and therapeutic way. I have found that it's been helpful for me to really normalize some of what people are going through in the midst of a crisis. Similar is this idea of parallel processing. So for some of y'all, you may not have, experienced parallel processing since you were a trainee going to school and still providing services to other students. I work with veterans. I am a veteran. I'm still in the military. And so for me, parallel processing happens pretty frequently. And I think it can be really growth producing if we take some time to reflect on it and sit in that moment. But the truth is that we are not exempt from experiencing COVID-19. We are experiencing this in the same way that many of our clients are. And it can, I think, can lead to stronger therapeutic relationship, but also stronger as a professional if we are taking the time to really process what that idea is like for us to be serving people that are experiencing the same thing that we are. Many of us are on the edges of our competence. So, like I said, I'm very comfortable and confident delivering behavioral health services within an emergency or crisis setting. I was less competent with telework. And I think that is many of us right now. And so we are really trying hard to get up to speed and to get our computer and technology and all of these things so that we can continue to provide services. But if you look at some of our ethics and the recommendations of the ethics, it's really kind of pushing us to the edges of what we would be comfortable with in a normal situation. So things like if you're trying a new modality, get supervision, practice a few times, get some mentorship, make sure you have CEUs, make sure you have practice with the technology. A lot of those were very difficult to do in, a 2-day time frame when everything went online. And that causes a lot of stress if you can remember back to when you were in your internship or your practicums where you were really just learning a lot of new things and not comfortable or confident in any of them. It can be really stressful. And so the same is true for if you are not comfortable or not typically providing care during a crisis or during emergency. That also is pushing our edges of competence in what does that look like? What does telework, what does therapy look like when it is a global pandemic? So there's a lot of unknowns right now, and that just can lead to us feeling not as comfortable, not as confident, more stress and anxiety, more questioning of our own abilities. So just, again, some considerations for you to be thinking about that may impact the way that not only are we providing services, but how we are in this process as well. Our access to resources, referrals, and operations may be very different than what they were prior to COVID-19. So if somebody was not appropriate for my services, was not short term, was not, needed more resources than what I could give them for outpatient therapy, I was able to provide those resources for them. And now that is not necessarily true. So where I am calling out of, our IOPs have closed, the emergency rooms are being very, very strict with who they are admitting. Almost all of our community resources have went to telehealth, and so uh, we're finding ourselves very limited in what we would normally present. And again, this is why framing it and documenting it as a response to an emergency or a crisis can be really helpful. You may be holding somebody, you may be waiting to refer to them until COVID-19 is over and they are able to access regular resources. Your operations may be very different, meaning things like, in telehealth, if somebody is actively suicidal or you're completing cams with them, that's not somebody that I would normally consider to be appropriate for telehealth, and having to make decisions about, do I just not see them telehealth, or do I see them telehealth and be as adaptive as possible? And so, just thinking about how those operations are going to look different, and it is a response to being in a global pandemic. This is something that I have recently seen come out. I've seen a little bit more discussion of this in the medical community, but I do think that we're going to continue to see conversations about this come up, and this idea about ethical considerations for denial of services or discrimination. Meaning, typically, if I'm a telework person and I only do telework, and somebody says, no, thank you, I don't want to do telework, I have the capacity to refer them to other people who do face-to-face. However, right now we're on a shelter in place, our physical location has closed, and so I don't have the option to give that to them. It also kind of speaks to, are we discriminating against people that are not as well off or are more privileged and have access to computers, to phones, to ability to internet, as opposed to some of those people that don't? So this is one of those more longer term things for us to be thinking about, and how going completely virtually online is just something that we should be thinking about, who we have the ability to continue to keep serving. Your orientation or approach to therapy may be challenged, meaning I'm a scientist practitioner. I typically am very concerned about things like data and assessments and evidence-based practices. And for operating within a crisis, you may not be able to have access to the things that you used to have access to. Again, this may be different for different people, depending on what programs, what platforms, what things you're using. But you may find yourself, if you practice predominantly from one approach or one orientation, struggling with what does that look like when you are providing services in the midst of an emergency. This is a kind of an offshoot of that, but your conceptualization of interventions, therapeutic versus therapy, supportive therapy, and holding space. So thinking a little bit about what is an intervention during crises. What is that going to look like? And so what I saw and heard is that people were trying to provide the same interventions that they were prior to COVID-19. And once they got online and once they were able to see people through telehealth, that they picked up where they left off and continued to provide the same services, the same therapy, the same intervention as prior to COVID. And without some really specific conversations and transparencies, that may not be the most effective for your clients. For some people, kind of supportive therapy or just being there holding space is something that they do naturally. And for other people that maybe are more short-term or solution-focused or problem-solving, that can be a really difficult, hard place to be, and particularly if we are not sure of what the timeline is. And so just kind of be thinking about what do I want my interventions to look like. What we know is that regardless of your orientation and conceptualization, according to most literature, is that the most important thing is the therapeutic relationship. And so I just want to encourage you that if you are really showing genuine care and you are trying to do the best that you can do, I think our clients are going to see that. And they may not think as much about things like, what does therapy mean or what intervention am I using, but does my therapist care about me? The idea of creativity, flexibility, and adaptability. As I said, I was trained as a scientist practitioner, and so oftentimes these words were not used in traditional Western European training. We value and have tried very hard as a field to be scientific, and so these words are often not brought into how we are training people or how we were trained to provide services. In the midst of a crisis, these are basically what you have to rely on, especially given that right now there is no rule book. So we have some precedent for providing services during natural disaster, and we have some precedent for providing telework, but there's none that I am aware of providing telework during a natural disaster or during a pandemic, and having both of those. And so we have really had to have some creativity, some flexibility, some adaptability, and being okay with that. In my experience, I have found that this can be really difficult for supervisees or newly licensed people. because again, they're just starting to develop what their ideas are, starting to develop what they're confident in, and may not necessarily be at a place where they feel comfortable playing with or being creative with certain interventions. And so if you are in a supervisor role or work with somebody that's newly licensed, really kind of encouraging them that this is okay and it's not maybe normally what we would do, but we are making thoughtful, intentional decisions about what we are doing and being able to justify why we were doing. So I know that we have definitely in my workplace had conversations about how, being able to respond to crises is an additional skill outside of some foundational skills. And so oftentimes even the idea of working within a traditional crisis is not something that's taught until much later on or through experience. Thinking about the messages that we are sending both explicitly and implicitly. So, this idea that what I found myself saying when I was introducing people to telework is things like, this is just like it is before, you're going to go ahead and sign in, you're going to complete this assessment. And really, I was contributing to this idea that things are as normal, business is normal, this is the same as it was. And so I have found myself starting to not really say that as much because I don't want that to be the message that I'm sending to them. Implicitly, what I have seen, and I've not seen this in other natural disasters, is kind of this idea that people are getting online and, posting pictures of happy dogs and, doing outreaches where we're just kind of doing jump rope and smiling. And, we did not do this during 9/11. And so thinking about, what messages are we sending about the expectation of how people are going to cope with this? Let's talk about a little bit about the considerations for those that we serve. So, of course, everybody is going to be different. I don't want to overgeneralize. And it's going to also, one of the challenges that I found is that I'm licensed in 3 different states and have family in New York. And each of those states have had very different responses and very different timelines. The same is true for Texas. And so, because Texas is an incredibly big state, um, there have been very, very different restrictions, very different timelines, very different kind of feels in the community. And so, I have found myself in Corpus Christi telling people it's still okay to go take a walk, but other people in other counties are saying like, no, we're not allowed to, we'll get fined if it's not essential. And so, just kind of being cognizant that everybody is not in the same place and not responding in the same ways. This is also true for symptomology. So for some people, they may see a decrease in their symptomology. So I see students that maybe are experiencing some sadness or some depression related to homesickness. And when they went home and are with their parents, they're no longer experiencing that symptomology. The opposite side of that is that people that had symptomology pretty significant or severe are obviously going to continue to experience that and maybe exasperated by it. And so just some permission for you to be cognizant that not everybody is going to respond the same way. Our community, our clients have been asked to continue their operations. And so our students been asked to, fill out homework and sign on to Zoom meetings. Our universities have went to online classes. Our workforce has been, as much as possible, transition to online. And so there is this feeling that this is kind of the expectation. Psychologically, what that can create is this idea of cognitive dissonance. And so it can be really, really difficult to imagine that there's this global pandemic going on outside of our doors and people are dying. And then also your homework is due. And so just something to think about in terms of, how difficult that can be to kind of resolve that cognitive dissonance. Another thing that I think is important to recognize here is that I was listening to and hearing a lot of clinicians say things like, oh, my clients aren't even impacted. They're saying like, no big deal. Like they haven't even thought about it. If you look at some of the literature from longer standing natural disasters, so things like Civil War, refugee camps, places where there's a lot of disaster or emergency on a longer term basis, one of the top coping skills that people use is nothing. And so I think if we can frame those statements in this idea that it's a coping mechanism to COVID-19, it can potentially change the way that we are conceptualizing what they are or are not doing. Just again, this idea that their chief complaints may be different. So continuing to assess and potentially being adaptive and adjusting fire with what they are wanting to work on. So certainly I have had students that prior to COVID-19, we're working on how to come out to their parents that they live with in a healthy and safe way. And now the chief complaint is, how do I hide my, newly budding female body after taking, hormones to my parents that I still live with, especially if this is going to be for the next month or two, and I'm afraid that I might get kicked out. Very survival based, very safety based, and very different than what it was prior to COVID-19. Uh, Diagnostic considerations. So I feel very blessed that I'm in a place where I do not have to work with or deal with billing. So I understand that for some people that do have to deal with RVUs and billing, that this can be a challenge. I would be cautious about providing intakes right now and looking at symptoms in the midst of a pandemic. For me, it would be very difficult right now to try and figure out how much of what they are struggling with is related to this environment versus more chronic. Obviously, I understand that we have some private practitioners on the line, and for people that are using billing, that's just something that they need to consider in order to, keep getting a salary. But I think that just being really thoughtful about our documentation and how we are doing that. In the military, there is a code in our EHR that is normal military stressors. And so I really like that. And I feel like if I could use that here for COVID-19, it would be normal, stressors to global pandemic. And so I would just encourage you to be cautious about over pathologizing how people are responding right now. One of the things that I have found myself saying is that these are normal reactions in an abnormal environment. And so while they in the long term may not necessarily be adaptive or healthy, right now is really about maintaining that idea of safety and survival. In all of those situations where I provided behavioral health care, never once since I started in 2005 have I ever provided anybody in a disaster with a worksheet or homework or an assessment. And yet, because we have the capacity to do that with telework, I have found myself doing that, and that's part of the policy for the place that I currently work at. I think it's really important for us to be thinking about the whys of giving these assessments. And so we use CCAPS, and that's just a self-report of 5 or 6 different areas of levels of distress for them. And I've had 2 students in the past week say, I don't have any social anxiety anymore because I don't see anybody. I haven't seen anybody in a month. And it was just kind of a reminder and really humbling for me to remember that what we used prior to COVID-19 outside of an emergency or a natural disaster, and thinking about why are we using that now. For many people, um, it can be alleviating some of their own anxiety about, asking direct questions about risk. It can be comforting to do the same things that you did previously. Obviously, I think it can certainly mitigate some risk management, but just for us to be thinking about how do we want to respond within a crisis. This idea of moral injury has been really fascinating to me working in the military. Most of the research that's currently out there is with service members and veterans. What I have seen is that I think we're going to see more continued dialogue about this outside of the military. And so I have started asking my clients, have you had to make any difficult decisions since COVID-19? And while the majority of them right now are not necessarily meeting the criteria of what it would be expected for moral injury, it has opened up conversations about, difficult decisions that people have had to make and how they're adapting. I think for some of our medical providers, my understanding is that, they are being asked to do things and to make decisions that only providers that have served in war zones have had to do, in deciding who, will get care and who will die. And so I'll be really interested to see what research and what conversations come out in the longer term about moral injury. I have found myself using psychological first aid and really just focusing on what the immediate needs of my clients are really day to day. Since all of that is changing, we are consistently getting changes from our local government, from our state government, from nationally, federally. And so, what worked one day may not necessarily be working right now. This idea, for some of you, if you are already a social justice warrior, this is a part of the work that you do. Maybe you work with marginalized or vulnerable populations already. This is not a new statement, but I think that we are going to we're going to see some considerable dialogue about this idea that the political is personal. And so, what I mean by that is, we are going to start hearing conversations about, who is essential workers and minimum wage? How do we think about healthcare? Ideas, I'm a border city, and ideas about immigration and how some of the um, uh, rules and regulations that have come out with this administration have kept some of our immigrants from seeking out testing or seeking out healthcare and hospitalization out of fear. I have certainly seen conversation from the disability um, population about, I have been asking for telework for many years and was told I can't do it, it can't be done, and now all of a sudden it can be. And it feels a little bit, resentful. And so I think we're just going to continue to see, more and more conversation about this. The idea of privilege, I think, is tied to the political is personal, but I thought that it deserved just a little bit of an extra emphasis, meaning, I think we are going to, we're going to see that marginalized and vulnerable populations um, are even more marginalized and even more vulnerable during COVID-19. I also have been reflectant of my own privilege in this, and so I'll kind of step off of topic for considerations for those who we serve and go back to us as providers. Um, I will share some examples. So early on, about a month ago, a colleague of mine in Hawaii was, feeling not well and decided to self-isolate, and then was still providing telework at home, and came back to work after the 14 days and realized that all of the work that she had done over the 2 weeks would not be compensated, because according to billing, you have to be in the office. And so I think she was really kind of devastated and unmotivated and just really sad about how our billing is in the US. And then I had other colleagues who are providing services where, I was almost chastising them, like, why are you still going in? Like, you're putting yourself at risk. You can provide services this way. And their response was, I work with a rural population. If I tell them to use the computer, they'll just stop coming to therapy. And not only will they lose their access to a therapist, but then I will also lose my way of paying for, food for my family and my salary. And so it's been pretty eye-opening to me to really kind of have to think about things that I have not necessarily had to think about, because that's not my day-to-day operations. I think for us as a field, we're going to see some continued dialogue and changes with things like PsychPack and telehealth and billing. And so I hope those changes are positive for us, but I think that it certainly is going to cause more conversation. Wanted to talk a little bit about the Kubler-Ross grief cycle. Obviously, this is not my model, and I don't mean to oversimplify how to view what's happening right now. But I have found that this model, or this explanation of grief, has been really helpful for helping my clients understand what's going on. And so if you don't like the model, you can also just use the language. To my knowledge, this has not been used in emergency or disaster management, but certainly the words and the language are used in there. And so I'm just going to give you a couple of examples of what I have heard or seen and how I'm describing this to my clients. So I'm really using this idea of grief and loss from a national or global level. So the loss of restrictions, the loss of freedom, the loss of birth plans and weddings, and really kind of explaining that there have been a lot of losses on a very national level here. And so bear with me as I use this as a way to conceptualize. This is also often, the Kubler-Ross model is often used more for longer term, not necessarily crisis. But again, I think this has just been an easy way for me to convey what some of our community is going through. So in denial, I think many of us seen this early on. And so, from the university level, this idea of like, yes, it's just going to be another week of spring break and these are cheaper tickets. It's time to go on a vacation and people are just exaggerating. This isn't really going to be a thing. It's not here in the US. There's no cases here in this state or in this county. They're never going to close Applebee's. We're a national restaurant. More people die from the flu. Only old people get this. And so, I think that we have enough examples now of denial that people can understand what that looks like on a very larger scale. The idea of anger. What do you mean that I have to stay home with my kids for a week? I'm still going on this cruise. I'm not a bad parent. This is dumb to have to seat everybody every other table. We're losing money. This is where we see panic buying for the anxiety. I didn't pay for online classes. Why am I having to pay tuition if I'm just going online? And so this is where we see a lot of frustration, irritation, anxiety, and then the idea of bargaining. So just let me get through this semester. Please let Zoom work. Just don't, I'm okay with going online classes, but don't let it impact graduation. I'll miss prom, but I don't want to miss my high school graduation. Let them, it's okay if they close the dining room, but don't let them close the restaurant completely and continue to do takeout. And then the idea of depression. This is typically something that people understand pretty well, but I have also been using this idea of this is where people can have this sense of wanting to run or flight. We're seeing a massive amount of people that are heading towards national parks and towards outside. Like, I just want to get away from this right now. I don't even want to think about it. And then this idea of acceptance. And so you will see people that, now that we have had our kids out of school for a little while, they have color block schedules. People are starting businesses. They are looking for ways to do acts of altruism. So they're making masks. They're, bringing food and things to essential workers. They're downloading software onto their personal computers. They're ordering office equipment to turn their home into a new office. They're really trying to find what is this new normal here. And I think it's really important to be able to describe it in a way that says that this is a cycle, meaning you can go back and forth and you can get stuck in a place. And as COVID-19 continues to change and the severity continues to change, I think we're also going to see people go back and forth through this model. I think we can see this in the Department of School, meaning in New York, where it's considered kind of a hotspot and epidemic, is that some of the schools have decided to close and said that we've met our academic requirements for the year, and this is a time that you should really be connecting with your families and being safe and focusing on loved ones. And a lot of that came out of parents kind of pushing back and saying, like, why are we making these kids do homework right now? Like, this is unreasonable, it's unacceptable, and also people are dying. And so again, this idea that they may go back and forth throughout this model. Other models that I have been using and that have been helpful for me to help conceptualize is psychological first aid, Maslow's hierarchy of need, and trauma-informed care. Psych first aid is typically used in the US, it's used more on a short-term basis. And there is some precedent for using it on a long term, but it's more typically done as embedded. So it's been challenging in kind of pushing my limits of creativity to use Psych First Aid in a telework position. And so just something to be thinking about. Maslow's hierarchy of needs right now, I would really be questioning who is safe and what is safety. And so I'm really looking at those bottom two on Maslow's hierarchy of needs. Uh, every day we're getting new information about who's at risk and, who needs to be tested. And we're getting more and more restrictions out of fear that more and more people are dying. And so, I think it would just be really difficult to work on some of those other things if there's not this sense of safety. Trauma-informed care has been helpful for me. I think one of the reasons that I like this is because it addresses that the provider, the clinician, is part of, trauma-informed care and part of the conceptualization. And I think that's really important to acknowledge that, we are part of this. For me, one of my guiding lights has been the idea of beneficence and non-maleficence, and that there is no guidebook, there is not, a precedent for this, and it's emergency and it's crisis, and we're all doing the best that we can. And if I use the guiding light of do no harm, I think, and I can, really thoughtfully think about what I'm doing and provide justification, that this has really helped me to be able to help my clients. At the bottom of this, we talk about how psychologists strive to be aware of their possible effect of their own mental health on their ability to work with. So I will end with this idea of self-care. I did not want to provide you with kind of tips or techniques to provide self-care. I think we all are very aware of ways to provide self-care, but more just kind of concepts. So this idea of self-compassion, we really are doing the best that we can do given that we are in the middle of a global pandemic. And so while we often use this word, or at least I do when I work with people that have experienced trauma, it's also okay for us to use that on ourselves. The idea of permission, in that, it's okay to give yourself permission to do things differently than what you did when it was business as usual. It's okay to do shorter sessions. It's okay to have time in between your clients. It's okay to, just kind of think about how you are going to survive this, and in that it's okay. This is a statement that I heard when I was very young, coming up in the mental health world, and a chaplain told me this, and I've kept it in mind ever since. The idea that even the best chaplains have a chaplain. And so we really need our support people right now, and to be actively engaging in that. Y'all, the idea of self-care is really important on a regular basis in a crisis or emergency situation when boundaries are being tested and caseloads are higher and work is higher and there's uncertainty. It can really impact our ability to provide services. And so certainly when I was deployed, there was a lot of discussion about how to keep our providers and our chaplains in the fight, because there was a lot of fear about having to send them home early. The Red Cross, when I deployed with Hurricane Isaac, the mission initially was to provide care for the community, and very quickly became to provide care for the community as well as the volunteers. And so it's really important that we do this. The last thing I will end on is a story that is when I first deployed. It was my first deployment. I was really worried about being that girl. I didn't want to fall out. I didn't want to embarrass myself. And so I took a lot of guidance and direction from people that had been there before. And so they would consistently tell me, you have to go eat breakfast, you have to go to the defect, you have to routine. And I listened to that for about a week and realized that every morning when I was going to get breakfast, I'm not really a breakfast person, I just was like irritated and aggravated. And so after about a week and a half, I found a coffee shop, and then every morning would go there and spend just about 30 minutes for me meditating and having a soothing drink and kind of having that time for myself. And that was helpful for me and what I needed for my self-care. And so I really encourage you to think about right now, it's important to listen to other people, but also to honor your experiences, that you're the expert of your own life and of your body, and that you know kind of what you need right now. And I hope that you are able to continue to engage in self-care and stay in the fight, because what you are doing is really invaluable. And I think that, this is a time when our clients are really going to see the impact of what we're doing. So with that, I will give you to the Q&A, and thank you so much for coming.
Thank you so much, Dr. Skelton, for your presentation. I know that I certainly was writing some little nuggets down for myself to keep in mind. So again, folks who are listening in, there is a Q&A box towards the bottom of your screen where you should be able to type in some messages, questions, thoughts, anything like that that you would like for Dr. Skelton to respond to. I will, while we're kind of waiting to see if others have some thoughts or questions, I will take a liberty here and ask a question myself. Who has raised a hand? I am not sure, Jessica, if you are able to jump in with what to do about raising hands. I know there should be a Q&A. Oh, there we go. Okay. All right. Oh, may we have a copy of the slides? Excellent question. And Dr. Skelton, is that okay with you if we share out your slides after this ends this evening?
Yes, you guys are more than welcome to have my slides, but then also please feel free to reach out if you have questions afterwards. It takes some time to process, think about consultation. Please just feel free to reach out, even if it's just for support, that's fine.
Perfect. Okay, and so so I will not take liberty and ask my question first because we've got excellent questions coming there. So we have several compliments coming in, so let me say that to you first of all. Also, a question is, how are you handling clients' political issues when they differ from your own?
So I think I work with a predominantly Hispanic population in Corpus Christi. And so I think, those conversations are often brought into our work that we're doing. And so when I'm just kind of listening for if there are things that they are struggling with that may be related to that. I'm also opening it up to conversation and giving them permission to bring up if there's any anger or other feelings that they are experiencing for that. Some of what I have heard more recently is the minimum wage conversation. And I think for me, I don't know that I necessarily am always sharing my own personal opinion about what my political stance is. I don't know that that's always beneficial, but certainly operating from that trauma-informed care approach, that, having some cultural humility and trying to understand where they're coming from and how that's impacting them is really where my conversations are going.
Great, thank you. Next question is, can you share about considerations for more than one person, as in like a parent-child, family, or couples using teletherapy?
So I don't have a lot of experience with that. I work predominantly with adults. I think that there is some stuff coming out about how to provide telehealth with children. And so what I have heard is that the idea of creativity and getting them to engage has actually been, at least from what I have read, has been helpful, and that there are some certain ways artistically and play therapy that a lot of times the kids are really enjoying.
Yeah, I would agree with that. So I am a child therapist, and so that is, or child and family therapist. So it is something I've gotten very creative suddenly about how I'm doing these things. So I appreciate that. I know there are platforms that are looking at ways to like share screens and share games and all kinds of things like that. So I'll interject a quick question here. So I heard today actually from one of our members that data is coming out that people of color are being disproportionately impacted by the virus. And so certainly, as you talked about discrimination and privilege, that statistic came back to my head. And so I was wondering, if you have thoughts, and this might go back to kind of political views as well, but thoughts on how to realistically address people's concerns about treatment and access to care in this difficult time.
Yeah, so I've also seen some of that literature, and if you're interested, I have a training in trauma-informed care and telehealth, and that really falls underneath that piece of cultural humility. And so one of my recommendations is to get some accurate, or as accurate information as we can about the communities of color that are being impacted. I think I saw an article earlier about even this idea of wearing masks, and people that are communities of color feeling like they can't wear masks because it's going to look criminal as opposed to non-communities of color, and how some things that we have not thought about are things that they're struggling with. And so for me, I'm just really kind of having conversations uh, about that. Certainly, I have had conversations with my students about things like family being stuck in Mexico, being unable to come back, being fearful about coming back. And for me, I think just being able to have those conversations and to be humble about it and to ask about their experiences. I might not have any answers for them, and my resources and my referrals may be challenged, and there may not be any better answers than there were prior to COVID. But I have found that cultural humility and openness to hearing what their concerns can be really therapeutic, and build and strengthen that relationship.
Perfect. Thank you. And next question, what does your experience tell you about delayed response to this experience? So in other words, once things are, quote, back to normal, do you think there will be delayed trauma response or other sorts of responses?
I certainly do. I think right now a lot of people are in survival mode. A lot of people are in denial mode, depending on where you are in the world. And so people are really just trying to do the best that they can do. They're in that fight, flight, or freeze mode. But I think in similar ways that we see longer term biological and symptomology responses to trauma, I think we are going to see that once people have that safety to explore what the impact of this has been in a longer term way.
Okay, excellent. You are also continuing to receive several compliments on the presentation. People are very appreciative of the information you've shared. Um, I'm actually going to take a little liberty. You've got a question that's come in about payment for Medicare patients who don't have access to computers and people are doing phone sessions. So I'll kind of take that for you at the moment. But TPA is gathering information on that, and Medicare has issued some guidance around telephone services being reimbursed, and we are constantly updating our TPA COVID-19 page with that sort of information. You can also feel free to either email myself, Megan Mooney, or Jessica McGee, our ED, with any specific questions about reimbursement concerns on particular plans, whether it be Medicare or any other. We are happy to make sure that you've got up-to-date information on that. So I think that's probably a little bit outside of the scope of what Dr. Skelton was planning to talk about. But I guess, sort of a related question that you did mention was around access to care, and people who don't even have access to computers, and so using telephone. And so do you have any other kind of guidance or thoughts on things such as like, the therapeutic relationship, or when you are missing those verbal cues because you can't do something via an audiovisual service?
Yeah, I mean, for me personally, I have just I found myself being really apologetic, in that, I'm sorry, this is not normally how I would like to do things. I really would like to be able to see you, to be face to face, but I can't right now. And in my experience, people have been really understanding, and so obviously that's not always going to be the case. But I am working with some people that, they may have access to computers, but their computer is in their family room. And so it's not a private place. And the phone, in their locked vehicle is a safer place for them to talk to me. And so I have some some liberty and some privilege to being able to do that based off of policies and procedures. You know, if you're looking at that trauma-informed care model, really kind of taking a look at what your systemic policies are in responding to this, and does it create the maximum amount of ability for people to access services regardless of, you know, their ability to get internet or phone or you know, the platform that you're using. And so I would just encourage you to be, you know, creative and to be transparent with whoever you're serving, and, you know, what your limitations are, what the benefits to telehealth are right now, and what the risks are. And, you know, all we can do is what we can do. And I think, you know, if you're genuine in that and you have that relationship, I think people, at least in my experience, for the most part, are willing to engage with that.
Great. Okay. I'm going to sneak in this one last question just to see if you have an answer for it. But I will say, Christina, that TPA would be happy to keep working on this if Dr. Skelton doesn't have an answer for you. But the question is, our billing office is saying that group therapy sessions are not going to be covered by telemedicine in Texas. So have you had experience with group sessions previously or during this current pandemic?
Yeah, so I can't speak a whole lot to the billing. You know, thinking, just kind of being creative and thinking about how do you want to do that if it's not going to be covered by insurance, and you know, what are your policies? And so I do not deal with billing, but we have opened up groups and group platforms, in that it's not a clinical group but more of a peer-to-peer facilitation, a social group, and so just a way for people to connect during COVID-19 bills. So that's not something that I have to concern myself. But some of what I have seen is, and I believe, correct me if I'm wrong, TPA is also doing this idea of, you know, if we are able to provide pro bono services in the midst of a crisis. And so if that is something that you think, you know, you are able to do or can do, and willing to do, that might be a way of encouraging that altruism, finding what your meaning is, and really just kind of being creative. And I just really, my heart goes out to y'all that are having to really deal with billing, because I don't think that we were ready for this. And prior to COVID-19, I think a lot of telehealth was treated as, you know, a option. And for rural mental health and for veterans, there's a lot of data out there about that. But other than that, they have not caught up with offering telehealth on such a national level. And so you guys have this like extra layer of complication. And so I'm really thankful for you that you're able to do that. And I hope that, you know, you can continue to advocate that things like billing and providing services and coverage, and kind of why is it different.
Thank you. I think, Jessica, you had something you wanted to add to that. Maybe not. There you go.
Oh, no, I do not. I just wanted to make sure that everyone knew that was what question we were on. I apologize.
Oh, okay. All right. Our behind the scenes messaging failing us here. Okay. Well, what I will add just to that, as I said, is TPA has been working on lots of different billing issues on behalf of members. Our priorities were certainly making sure that we have individual and family sessions covered across the board. And so if we are having problems with group sessions not being covered, or people are being told that's not going to be authorized, please do reach out to myself or Jessica, because we are happy to add that to our list of things that we keep advocating for, to make sure we've got reimbursement for all the relevant CPT codes for services being provided. We are a few minutes over time, so out of respect for all of you joining us, and particularly for Dr. Skelton, we are going to pull this to a close now. I do so much appreciate Dr. Skelton's generous gift of her time this evening for sharing this with us, and for all of you for joining. Really appreciate all the hard work that everybody is doing out there, and please do not hesitate to reach out to us within TPA leadership if we can be of further service to you all. Thank you so much, and have a good evening.